Hello and welcome to a special interview for The Wire. As we approach the end of Lockdown 4, what is the true picture of the spread of COVID-19 in India and what are the steps the government now needs to take? Those are two critical issues I should put today to Professor of Physics and Biology at Ashoka University and one of India's foremost mathematical modelers in disease modeling, Gautam Menon. Professor Menon, as of 9 a.m. today, Saturday, the 30th of May, the Ministry of Health website says that India has 173,763 cases, which is more than double China, and we've also overtaken China in terms of deaths. Secondly, the Hindustan Times says that the daily average of cases and deaths calculated on a weekly basis has been rising every single week for the last 9 weeks. And finally, Worldometer says that although India is number 9 in terms of overall cases, in terms of active cases, we're at 5th position. Does all of this together suggest that the fight against the virus is getting steadily tougher?
First, thank you for having me on your program, Karan. And I think the right way to think about it is that we're entering a new phase in our ability to deal with the virus, that we're now emerging from several weeks of lockdown. The lockdown has helped to some extent in curtailing the spread of the virus, but there's no getting away from the fact that this is a pandemic disease. It's spreading across the country. And the only thing that we can do at this point is really think about efforts to mitigate the spread. So what we can hope to do is to slow it down appropriately so that that we can always ensure that our healthcare system is able to cope with it at any point of time.
I want very much to talk about the gains from the lockdown and steps that we need to do to mitigate or slow it down. But first of all, to come back to those statistics I deliberately cited, do they suggest that the fight is becoming tougher?
Right now, from what we know, the situation is certainly better than it could have been. The doubling time is around, let's say, 15 days, somewhere between 15 and 20 days. If we can concentrate on keeping the gains from that particular number, the fact that we've now managed to spread it out, that is good for us. So the real question is what happens ahead and to what extent we can preserve everything that we have done up to this point going forward. So let me just sort of give you an example. If there was some way we could keep every Indian in a box for 28 days and not communicating with anyone else, then that would be a way of cutting the virus off completely. If, however, we have to go back to a situation where people begin to interact with each other, all we can do really is to ensure that some level of distancing, mask wearing, continues to remain in place. With that, we can control it. So as I said, we're moving into a new phase. It's uncertain. We're not very sure what will happen in the future, but it's not as dire, I think, as it might have been.
You took comfort from the doubling rate, which is roughly 13 days in India, but there are countries in Europe where the number of people there are in the late 20,000s or 30,000s, and their doubling rate is 20 days and 35 days. So in comparison to them, our doubling rate is not such a great doubling rate at all.
It depends on where you are relative to the growth of the epidemic. So, for example, I think in India, you're at an early stage compared to many countries in Europe, which have seen a peak and have seen the sort of downturn from that peak. At this point, from what we know, our best bet is to be able to slow it down as much as possible. And as I said, keep the gains of the past in mind. And when we move towards the future, to really try and ensure that we keep this principle that we're all in a separate box and interact as weakly with each other as possible through any measure that we can actually use when we go back to what seems like a new normal life.
Now, lockdown 4 ends in roughly 24, 36 hours' time. What do you believe the 4 lockdowns have achieved? Initially, we had hoped they would flatten the curve. That clearly hasn't happened, although the curve is not rising as steeply as we had feared. But it is still rising. So what would you say are the gains from the lockdown?
I think the main gain is that we've managed to slow the progress of the disease. So all of the work that we've done and what other people have done seem to suggest that from a position where you had a doubling time of somewhere between 3 and 5 days initially, although with a smaller base of cases, you've now been able to stretch it out to somewhere around 15 days, let's say. So the lockdown did help in that sense. It certainly did manage to avert some number of deaths that can be attributed solely to COVID-19. And as I said, the intent of the lockdown, really, if you go back to it, is to be able to put health systems in place to be able to deal with what will inevitably happen once you relax the lockdown, which is an increase of cases. I think every model will predict that you will see an increase of cases once you move away from the lockdown. Okay. What you need to do is to be able to be prepared for it at that point.
Well, last Friday, the government announced results of mathematical modeling that it had done, and these suggested that perhaps as many as 2.9 million cases had been prevented, perhaps as many as 78,000 deaths had been averted. But some of the modeling was done by the Boston Consultancy Group, which, as far as I know, are not experts in public health, and I'm not at all aware of their expertise in mathematical modeling either. You, on the other hand, are a renowned mathematical modeler. So, to begin with, what do you make of this claim of 2.9 million cases being averted, 78,000 deaths being prevented?
So our own numbers are somewhat more conservative than those. I can understand why the government would want to put a good face upon it, to say that there has been some positives that are associated to the lockdown. And to an extent, I agree with it. There certainly have been positives that are associated with the lockdown in terms of controlling the number of cases, controlling the rate at which they grow, and in terms of curbing the number of
Can I
hospital
interrupt?
deaths.
We
Yeah.
know all of that, sir. You've told us before that the lockdown has controlled the rate of growth. I'm asking you a specific question. Do you believe this modeling the government has put out, that as much as 2.9 million cases have been prevented, as many as 78,000 deaths have been averted? Do you believe that, or do you have doubts about it?
So I believe that deaths have been averted. I would argue with the scale of that, because the scale of the numbers that you just talked about are not the scale of numbers that we actually see. And the main issue there is that we really don't know what went into determining these numbers. So right now, with any of the models that the government presented, with the BCG number being only one of them, there's a model that comes from the ISI, there's a model that comes from retired public health officials, etc. Unfortunately, we don't know anything about what went into determining those numbers. And I think that is really a far more serious issue that we should be considering. For any model, one needs to be able to be completely transparent to understand where estimates come from, what went into those estimates, and what the possible errors in those estimates are.
If
Only
I
when you can critique a model are you able to understand why it predicted what it did, and why there is some reason to either believe it or not to believe it.
In fact, if I recall correctly, the Boston Consultancy Globe prediction at the upper end claimed that 2.1 lakh deaths had been averted. That is the upper end of the Boston Consultancy prediction. On the other hand, I know that you have done modeling in terms of deaths, and your figures are a lot lower. Share with us, what are your figures? Because they are remarkably lower compared to the upper end of the Boston Consultancy Globe predicting 2.1 lakh deaths prevented.
In fact, our numbers are at the lower end of all of the estimates that were presented. Our numbers range roughly between about 8,000 to about 32,000, with a number like 26,000 deaths averted being our best guess for the numbers. Exactly as you pointed out, the range of figures that have been exhibited, with the BCG group being a much larger number, goes up to about 2.1 lakhs, and the lower limit of that is about 38,000. And the BCG estimates are on the higher side. The other estimates are a little above what we've said, maybe about 20 to 30% above what we've said. The advantage that I can tell you about our model vis-a-vis the other model is that our model is completely transparent. Everything that goes into it is explicitly prescribed. You can look at it on the net at the detailed description. And there's even a dashboard on which you can try out your own estimates for these numbers and check what are the number of deaths, etc., that they lead to. As I said before, it's important that any modeling exercise be completely transparent. And that, I think, is something that one should encourage. And really, numbers in themselves have no meaning at all unless you know how they were obtained. And it's important to stress this point of transparency being really crucial to any public health exercise, especially where modeling is concerned.
You
There really
know,
is no reason to
can
not be transparent.
can I interrupt there? I want to ask you, given the range of this modeling exercise, from 8,000, which is the low end of your range, up to 2.1 lakh, which is the upper end of the Boston Consultancy Globe range, you have virtually 200,000. It's a huge range. And it reminds me of what Dr. Randeep Guleria, the director of the All India Institute of Medical Sciences, said to me in an interview last week. He said, mathematical modeling is rough guessing. How useful is this sort of modeling?
So that depends upon how you think about models and what they bring. First of all of us model. The government models, even in the absence of a mathematical model, must always have some prediction of what might happen next week, the week after that, how many ventilators you might need in a certain area in Bombay, for example, associated with Dharavi, or in Chennai, or in Delhi, etc., etc. So the question is, where do these numbers come from? One is that you could just guess, and that certainly is one possible way of doing it. The other is to try and establish as rigorously as possible what that number might be, state your assumptions, state the ranges in which they might vary, and then update these predictions as you get closer and closer to that date. So models should not be static. They should be thought of as really dynamic, where as we learn more and we
Can,
get
can
better
I,
data about the
yeah,
situation, we can
can,
improve on what
can
we
I
predict.
interrupt again? Given that the government's models have a huge range, given that they're done by people like the Boston Consultancy Group, who do not really have a track record of public health that I'm aware of, and given that the government hasn't made transparent the assumptions on which its modeling is done, then how credible are these figures? Answer that for me directly rather than diplomatically.
So, as I said, unless I know what went into these models, I'm in no position to even critique them. So I have no idea of whether they made better assumptions than we did, if they're more informed by the actual data, which we haven't seen. And remember that one bottleneck with all models is the quality of data that you feed into them. If you put in garbage, you'll get garbage out. So we, from outside the government sphere, we rely on what is public data. So we rely on trends that are reported on various types of websites that aggregate all of the data that is provided to it, on newspaper reports, put all of these things together to get estimates for what are the number of deaths, for example. From there, what are the number of
That's
cases
right.
that we could
So
detect. All of this is what we have
I
to do.
hate
So
interrupting because I'm trying to get you to give me a definitive opinion on the government, and you're saying that because you don't know what the government's modeling is based upon, you can't even critique it. In other words, you're saying the government has said to us, take this on trust. We won't tell you on what basis, on what assumptions we come to these end results. Just take them on trust.
I
That's
agree
what the government
completely.
is effectively saying.
I agree completely. By showing a set of numbers with no indication of how they were obtained, that's essentially what you are being told, that don't question these. If you had, in the sort of sad thing is, I see no reason why there shouldn't have been an explanation. This isn't rocket science. People could have looked at it, examined it, looked at the assumptions, critiqued it, come up with better models, or even suggestions to improve these models, or taken them on trust once they understood how good they were or how bad they were. It's a
Okay.
decision that one can make.
Let's then move beyond the gains of the lockdown, which we've discussed deliberately in terms of the government's claim of the number of cases averted, the number of deaths prevented. Let's come now to the situation as we see it at the moment. And it's this: the government insists that there is no community transmission taking place. But most people, when they find that we've got 173,000 plus cases, find this very hard to believe. And top epidemiologists like T. Jacob John simply do not accept the government's point of view. Do you accept that we haven't entered the stage of community transmission?
No, I don't think so. I think this is just terminology at the moment. I certainly think that we are seeing a sort of background of cases for which we have no link to an original case that came in from abroad. So let me just tell you what community transmission, what the idea behind it is. At the beginning of a pandemic, you can try and trace all of the cases that you're seeing to some initial case that may have come in from abroad, for example, from Wuhan or from Saudi Arabia or from Italy and so on. There are some advantages to doing this because then you can establish a chain of causality between the first case and the case that you're seeing now or a case that you might be seeing a few weeks down the line. Beyond the point, once it expands to a certain large number of people infected, imposing that testing of contacts and even trying to establish that connection makes no sense at all. It just becomes much harder.
I
Then
mean,
you begin to have
again,
cases
so
that
I
have
mean,
no
nothing
explanation.
again,
Yeah.
because we all know what community transmission means. I'm asking a slightly different question, not what it means. Have we entered that stage? Because the government keeps insisting we haven't. I want you to tell me what is your belief.
I would certainly think that we have entered the community transmission stage, and that already, even a month and a half ago, when we had an example of someone going from Delhi to Chennai in a train who turned up COVID positive, already with no foreign travel, no known contacts, etc., there was already some reason to assume that he was a case of community transmission, where you just could not establish any link to a previous case or establish a connection.
The
So I think
case
there has been community transmission for a while. At this point is really terminology, and I don't see
that
why one
case
needs
you're
to.
talking about
Yeah.
happened on the 18th of March.
Mhm.
That means we've been in community transmission from the 18th of March, over 2 months. What do you make of the fact that the government keeps denying it? Is it deliberately trying to pull the wool over the eyes of the country? Or have they found some new definition of community transmission, which is radically different to yours and different to T. Jacob John?
So as I said, I don't really understand. I think most epidemiologists at this point would say that we are at a stage of community transmission, and the focus now should be on mitigation rather than anything else. And if that's the term that they choose, I mean, I don't really understand why they choose to insist on that point, because I don't think it's sort of worth stressing at this point. It's really not.
Let
And
me
it's,
go to another point. As we talk, tens of millions of migrants are returning to their villages in rural UP, Bihar, Telangana, Bengal, Orissa. And it's widely reported in the papers that their positivity rate is perhaps double, maybe in some cases triple the national average. Do you believe we're likely to see a surge of cases in these rural hinterlands?
I think we certainly are, and that is something that we should sort of account for in whatever public health measures that we take in the future. The one slight positive, if there any indeed is one, is that people are now more sensitized to how to deal with the disease, even in remote areas of India. So even as they go back to villages, to small towns all over the country, there certainly is a sense of preparation in place, of knowing what to do and to what sort of appropriate physical distancing measures one has to have in place. If this will, if anything, help us in preventing the associated spread with the migrants who are going back to their individual states.
Now, you're a modeler, you're a renowned modeler. When do you believe we're going to hit the peak? There are some people who say it will be June, July, others say August, September. What's your assessment? When will we hit the peak?
Okay, that's a hard question, and ideally, one would like to push it forward as much as possible, push it backwards, sorry, towards later in the year as much as possible. With the current numbers that we have, as we exit the lockout right now, we would expect the peak around the end of August, say the middle to the end of August. If, as we anticipate, the reproductive ratio will go up to some extent, we expect that to come even earlier. So maybe even July, the middle of July is also a possibility. So somewhere between the middle of July and the end of August, given the current range of numbers, I think is a feasibility. It's unlikely that we will see it much earlier than that.
Can I put this to you? You've got tens of millions of returning migrants going into rural India, each of whom are supposed to have a positivity rate that is double or triple the national average. Might that not ensure the peak happens a lot earlier? 2 or 3 weeks from now, which is the middle or third week of June, when these people have returned, settled down, they may have infected people, they may have passed it on, you could have a peak. And worse still, it may then have shifted from urban India into rural India, where health facilities may not be adequate and testing may not be perfect. Is that a fear at the back of your mind?
You should remember that rural India is less dense than urban India. So certainly the ability to spread, it would be much more in distant rural parts of India compared to, say, highly dense Bombay. So in a sense, that could mitigate affairs a little bit. Remember that these are younger populations. So in a sense, they will manage to do better with the disease. Some of them may even be completely asymptomatic for the disease. And as I said, I think the important thing is that India is better prepared now than it was 2 months ago, given the lockout, given the lockdown, given the information that we now have. So that, if anything, will really be crucial in our ability to control that spread. So I'm not as negative about this sort of global. Already, 700 odd districts have already reported a case of COVID-19. So in a
Let's
sense, it's
then,
already there.
let's then come to some of the statistics from which the government takes great comfort. And the first is the recovery rate. As of this morning, it's at 42.8%. But I noticed that Italy, with over 33,000 deaths, has a recovery rate of 65%. Spain, with over 27,000 deaths, has a recovery rate of 69%. So clearly, a high recovery rate can go side by side with a very disturbingly large number of deaths. The two don't preclude each other. So my question is simple. How much comfort can we take from India's recovery rate?
Okay, so the one thing that you should note is that given this disease, most people will recover from it. In fact, even if you say that about a third of people or more are asymptomatic for the disease, even among the symptomatic fraction, even you assume that about 85% of them will recover without a problem, about 15% of them will need some sort of critical care, and about 2% of them, which is our best guess, will actually die. So that is, in a sense, very good in terms of mortality rates, just because it's a
But
relatively small
again,
number who
forgive me,
actually die.
sir, we are
Yeah.
getting into a bit of theoretical explanation about what a recovery rate is. But my question was different. How much comfort can we take from India's recovery rate? Love Agarwal stresses it every time he has a press conference. But I notice that the recovery rates of Italy and Spain are considerably better, and they have deaths in the late 20s and early 30,000s. So my question is, how much comfort can we take from our recovery rate, or is the government stressing something which may not be that significant?
I would say that at this point, it's not very significant because the recovery rate really depends upon when you choose to make the measurement. So suppose you had sort of 101 people with the disease and one of them was supposed to die. If you caught them in the beginning, then you would have only infections and no deaths. If you caught them at the end, you would have one death and whatever you would make of the number of infections depending upon your testing. If you could only test one out of that 100, you would have one death and one person who you decided to be infected. So 50% of the people infected would have died. But if you managed to test all of them, then you would have one person out of 100, out of 101 who actually died. So that's a much, so where you do this measurement exactly makes a difference. And these things are usually best done retrospectively, going back at the end of the pandemic to figure out what these numbers are.
Okay. Let's then come to something else from which our government draws a lot of comfort. First of all, it's the mortality rate. On Tuesday, the 26th, Love Agarwal announced three versions of it. In percentage terms, he said it was 2.87%. Per lakh, he said it was 0.3. Per million, he said it was 3.08. And he compared that to a global average, which is 6.36. We also know from the government that our positivity rate is only 4.84, roughly 4.9, compared to Spain, which is 10.5, and UK, which is 11.7. And finally, Love Agarwal told us that only 3% of Indian cases get to ICU, and under 0.5% need ventilator. But the global average again is around 3. So take all of this combined, the mortality rate, the positivity rate, the fact that only 3% get to ICU. Does it suggest that the virus is behaving differently in India than it has in Europe and America?
No, that doesn't really suggest that, because what you have to keep in mind is that ours is a young population. The median age in India is 28. Median age in Bangladesh is even lower than that, whereas the median age in the UK is some number around 42, 43. This disease is known to hit older people more hard than it does younger people. So if in the UK you have more than 15% of people aged above 65, for India the comparable number would be about 5%. So mortalities can only be understood in conjunction with what you know about a particular population. So that's an important number. The fact that we are a young population certainly is in our advantage. So that's automatically should be factored into any number that you calculate for these. The second point is it depends upon the time at which you report. For example, the deaths that you see today are a consequence of infections that you have that have happened about 2 weeks ago or 3 weeks ago, depending upon how exactly the disease manifested in specific patients. So the correlation between the deaths and the infections is delayed. And that's another thing to sort of worry about and to think about it. The third thing to remember is that when people actually come into hospitals is actually crucial. In the beginning, you were seeing people who came in towards the terminal stages of the disease. And then they died within about 3 to 5 days of actually reaching the hospital. Now you're seeing, because you're testing a little more broadly, you're seeing people with no symptoms at all who come into the hospital. You're seeing people who come in early so that you can treat them. All of these keep the mortality rates coming down. And all of these ensure that these numbers in absolute terms fairly small.
I'm very interested by your answer because you've given me three good reasons for saying that the conclusion that the statistics are cited suggest that in fact the virus is behaving differently in India compared to Europe and America is a wrong conclusion. However, and this is critical, however, Health Minister Harsh Vardhan told the Economic Times last Saturday, the 23rd, and I'm quoting him, the virus is not that virulent. On the same day, again, Saturday, the 23rd, Randeep Guleria, the director of AIMS, said to me in an interview that the government had a certain amount of data that suggested the virus had mutated, that its virulence had diminished, but, he added, this needed to be confirmed. You're saying something very different. You're saying the virus is as virulent in India as it is elsewhere. It's our age that is protecting us and keeping a low mortality rate. It's the fact that people are now going to hospital earlier, which means they can be treated. So you're saying something very different to Harsh Vardhan.
So as I understand it, there really is no reason to think at all that the virus in India is different from the virus abroad. If viruses are in different clades, which means they're a little different from each other. So the clade that is most commonly seen in Europe and other parts of the world is something called the A2A clade. And the percentages for that are about 50%. In India, it's about 46%, the best that we know. So there really does seem to be no reason to believe that Indians are in any sense special in any way. It's all of these other factors that I would currently think are more important. I've certainly seen nothing in any published literature or in fact, in my conversations with anyone who works in virology that would suggest that we know something about the Indian virus that suggests that it's very different from what we know about the virus abroad.
So just to be certain, you disagree with the minister who says it's not that virulent. You're also apparently disagreeing with Randeep Guleria, who said to me that there was some data that suggested the virus had mutated and its virulence had diminished, even though it needed to be confirmed. You're disagreeing with both of them.
I don't have access to the data that Dr. Guleria had, so I can't comment. Maybe he does have, he is seeing a part of the data that I haven't. What I can say is based on what I've seen so far, there seems to be no reason to believe that the Indian virus is any different from the virus abroad.
Let's take a break at that point. When I come back, Professor Menon, I want to talk to you about that second aspect of this interview. What are the steps that are now critical for the government to take? But first, a break. Welcome back to a special interview for The Wire. My guest is Professor of Physics and Biology at Ashoka University and one of India's foremost mathematical modelers in disease modeling, Gautam Menon. Professor Menon, let's come to the second question I want to ask you. What are the steps the government now needs to take? As of 9 a.m. today, Saturday, the 30th of May, the Health Ministry website says that India has done a total of 3.6 million tests. Yesterday, we did just over 127,000. Now, that may sound like huge numbers, but actually, per million, it's only 2,619 compared to Spain's 76,000 and Italy's 62,000. So, given the size of our population, which is infinitely more than Spain and Italy, do we need to ramp up testing?
So we certainly need to ramp up testing, and there are sort of two ways in which one does it. One is to test whether someone actually has the disease, so that to see if someone who clinically reports or with COVID-like symptoms or someone who is a contact of someone with COVID-like symptoms actually does have the disease at that point. But now an equally important, perhaps even more important question that we can ask is how many people in the population actually have had the disease in the past. So that will give you an idea of the general prevalence of the infection in the country. These tests are a different class of tests. They're called serological tests. And the information from that is absolutely crucial to us at this point, because then we will know to what extent the infection has spread, what should we budget for in the future. So that will tell us where we stand at this point.
Let me stop you there, because the ICMR has announced just a day or two ago that they are doing a major serological sentinel survey in 69 of India's 739 districts. And clearly, that is what you believe should be done, so that news is welcome to you. But the question is just 69 districts out of 739 sufficient? Because that's less than 10% of India's districts.
So I look upon that as a sort of pilot project. I'm sure they're going to roll this out to all the districts. I'm extremely interested in the results, and I think most of us who think about this field are very interested in finding out what they become. The whole process is well defined. They've laid them out, and they look at regions where you expect a high incidence of cases, where you expect a medium incidence and a small incidence. So the information from all of this, even with the districts that they have selected, should be very valuable to us. And I do hope they will roll it out to all the districts in the country shortly after that.
But you said you believe the choice of 69 out of 739 districts is just a pilot project. So you're saying, although you haven't said it in so many words, as a pilot project, this is a good start. But if this is all that they intend to do, and they're going to stop after this, then it's far too little.
I agree. So I would certainly expect that they would roll this out to all of the 730 odd districts in the country. And of course, as people move back, as you said, the point that you made about migrants moving back to distant parts of the country and to other districts where they haven't seen many cases of COVID-19 before, this will begin to look at the question of how is the disease spreading. And it's not enough to do it just once. You have to keep doing it at intervals of about a few weeks so that you can assess this question. How much is the disease spreading? How many more infecteds are there now as opposed to 2 weeks ago or 3 weeks ago? And it's only with this sort of epidemiological information that we can make good policy. And that's really crucial at this point.
Then let me ask you this. As someone who's a foremost mathematical modeler, to what extent is the availability of accurate data a problem for you?
That is a genuine problem. So let me give you some examples of where better data might have been useful. One thing that you could ask is, at what point did COVID begin to spread in the population based on what we know? So one natural way of asking this question is to say, how many people were displaying symptoms that were like COVID around the time of, let's say, February, March, April, May, et cetera, and to what extent did that number change? So because COVID-19 is, in a sense, its symptoms are somewhat like influenza, the question that you might want to ask is, how many people reported with influenza-like symptoms to hospitals and clinics, etc., during that period? Now, the agency that is charged with looking
Are
at
you
this,
saying that that information is not available?
yeah,
Hospitals
so
don't have a record of how many people reported with influenza-like symptoms around that period being 30th January?
So this information is collected by what is called the NCDC, the National Center for Disease Control, under the IDSP, the Integrated Disease Surveillance Program. And around the middle of February, they stopped publishing their weekly reports of these cases. So they had this uninterrupted reporting for sort of years before that, which is a very, very useful source of information. But beyond the 15th of February, I think they stopped reporting in early February. Beyond the 15th of February, there is no such report at all. So this has really stymied the efforts of people to try and understand the nature of spread completely. And again, I see no reason why they should have discontinued a process that had started much earlier. But
Who
let me
is
give
the
you another.
organization? Can you name the organization again that has discontinued the publication of its weekly information?
The NCDC, the National Center for Disease Control, under which the Integrated Disease Surveillance Program. I can give you another example, which is a discrepancy that was pointed out by a health journalist, Anup Bhuyan, between the number of cases and the number of tests over a 2-week period in the middle of March. And this number, this difference between the number of tests done and the number of people who were tested, remains at a constant figure of 890 over that entire period. So this has been a question of what happened with this data. Was it really that no one was tested in that period? Even though both of these numbers were increasing, the difference remained absolutely constant.
Can I ask you this?
Yeah.
Why is this information being withheld, or why have they stopped making public information they previously did on a weekly basis? Are they, and obviously this is your suspicion I'm asking you for, are they holding back information because they don't want to worry people? Are they questioning it and therefore they don't believe it's accurate? What do you think would be the explanation? Because it's a strange thing to do, to hold back information just when it's actually critical that it should be transparent and available.
So I have no explanation for that. And one certain possibility is that they're worried that whatever results might emerge from making this data public would worry people excessively. But again, you cannot do public health unless again you're transparent with your measurements. And people have to be able to look at the data. People have to be able to understand where it comes and to be able to look at trends. The expertise for doing this is not confined purely to the government. There are many people who could contribute to the understanding of data such as this, who might be able to look at trends and look and examine the behavior of what might be going on in a more constructive and creative way than just government agencies looking at it.
Now, you have also, as a modeler yourself, done work which suggests that India could have as many as 10 million undetected infected people. Very quickly, how do you know this? Or what leads you to this conclusion?
So I'm part of a group called the Indian Scientists Response to COVID-19. And as part of that group, we work. So this is a group of about 600 scientists from all over the country, media people, artists, etc., who work on what the public or the scientific public might take out of COVID. So one thing that we do is to work on models for COVID-19, which are in a sense very advanced, very detailed, and they're specifically constructed for India. So we have right now we model every state of India, every district of India.
Specifically, to this specifically. How do you know that we could have, or what leads you to believe we could have 10 million undetected virus carriers?
Because that's what we put into our model. We try and see, let us assume that the deaths that we get out of the government record of deaths is correct, and we try and fit our model to that. From that, we say, given that, what is our best estimate for the number of people who are totally infected in the population? Our best estimates are in the range of exactly as you said, a little less than a million at this point. And this is a little less than 10 million at this point. And this means that we're not seeing roughly 1 in about 20 to 30 infections. That's a number that we have. We have not seen the analogous number that must have come out of the other calculations.
I'm interrupting you again because I think it's important that the audience should understand what you're saying. Have I correctly understood? You're saying on the basis that the government's figure for the number dead is correct, you've worked backwards and come to the conclusion that there must be 10 million more infected people if this is the number that have died?
That's pretty much the case. That given the numbers for death, there's a certain number that you can estimate for the number of people who must have been infected, and there is a gap between the number who have tested positive and the number of infections that we predict.
And
That would, to some extent, that gap depends upon the assumptions that you put into the model. But I think anywhere between a factor of 10 to a factor of 30 between every detected case and every undetected case is probably the right ballpark figure.
And this link between the number dead and the number that you believe are infected, and therefore the conclusion that 10 million undetected but infected people exist, is based upon, I assume, some knowledge or some understanding of the RO factor.
Yes. So all of this is very explicitly described in the modeling, the work that we do, that is made completely public. So every detail of what we do is public and anyone can actually look at it and critique it. We would like to know what the other model that we produced. Go on. Yeah.
What is the website where people can go to find out the assumptions and the details on which you've come to this conclusion? Can you name the website?
Website is insightcovid.in, the Indian scientist response to COVID. It's called Insight COVID, and they can just search for that on Google and examine the results. So this is in the form of 3 reports, one that describes the model. The last report is one that looks at this question of how many excess deaths there were, and that's where we came up with our estimate of somewhere between 18,000 and between 8,000 and about 32,000 deaths. And there we want to explain that the model predicts a large number of undetected infections, and we estimate that amount.
These large number of undetected infections, which you say could be as many as 10 million, I take it that these are largely, if not almost entirely, asymptomatic carriers.
Yes, that's the case. A large number of them are asymptomatic. And that, again, the exact way in which you apportion the numbers of infected between asymptomatic and symptomatic enters a calculation. We've been very conservative with that. In fact, currently people think that 80% of infections might be asymptomatic. We've been much more conservative. Our number is around 33% or 40% with that, which is a large range that's quoted.
If you have 10 million people in the population who are asymptomatic carriers of the virus, how much of a cause of concern are they? Are they spreading it? Because earlier, when COVID first became a cause of concern, it was believed that asymptomatic carriers could infect others. Now there seem to be question marks about how good they are at infecting others, and people say they won't infect others or they may not do so at the same rate. So what is your assessment of how much of a concern are these 10 million?
So that's an extremely interesting question, and the science is still evolving on that particular issue. Right now, I think people are tending a little bit to believe that even though asymptomatic individuals have the same level of virus, the viral load as symptomatic individuals, they're just possibly less efficient at transferring it to other people. If this is true, that would be a great step forward in our ability to deal with the disease, because then we could ask that maybe it's not necessary to rigorously quarantine an asymptomatic carrier. Once you test them, maybe it's enough to quarantine them at home and prevent some minimal contact with other people. We don't know this yet, and this is extremely important to establish. And as the science evolves over the next few weeks, we will know this better.
We end on a sobering note. You believe that the number of deaths averted is a lot less what the government claims. It could be as low as just 8,000 compared to the Boston Consultancy Group figure, which is as high as 2.1 lakh. Secondly, you believe that there are a very sizable number of undetected infections, which may be as much as 10 million. That these are very largely and likely to be asymptomatic carriers. We don't know quite clearly how much they will infect others, but we hope they won't do much damage. Clearly, this suggests to me that we are still grappling to control the disease. We are not on top of it as yet. Your silence is...
No, I just asked, I wasn't sure whether you wanted me to respond to that specifically. I'm actually somewhat more positive about it than you are. This is an epidemic that every country in the world is facing and is dealing with it in whatever way we can. We are a crowded country. We have problems that are unique to us, and yet we managed to do certain really important things. I think the messaging from the top has been consistent, and that's really the strongest thing that we have. Unlike, for example, Donald Trump or the British Prime Minister, we have been consistent from the beginning in pointing out that this is a disease that one must be prepared for, that have take adequate precautions for. And now a large fraction of the country knows that this is true and knows what precautions to take in terms of distancing, mask wearing, hand washing, etc. The rate at which the number of cases is increasing is right now small. The doubling time is large. If we keep it at that, we can hope to maintain some level of control over how this disease spreads. I hope that that is what will happen in the future. We have the other thing that I must point out is the role of science. Remember
Okay.
that within 10 days, we found out the sequence of the virus, we found out how to test for it. This would have been unthinkable 30 years ago, 20 years ago.
All right. I'll leave it there. All I'll add for the sake of the audience is whilst you believe our doubling time at 13 days is large, there are countries in Europe who've seen many, many more deaths than us who have a doubling time of 20 and even 35 days. And compared to them, our doubling time looks worryingly small. But let's not make that an issue. I'm simply pointing that out because I think it's important that the audience should be aware that what we consider large, 13 days as a doubling time, is really very small compared to what is the doubling time in Europe, which goes up to 35 days in some instances. But we leave it there. Thank you very much for talking to me, Professor Menon. Stay safe.
Thank you, Karan.
To receive instant updates on all videos from The Wire, click the subscribe button and hit the bell icon. Pay to support independent journalism. Click the link in the description and choose the amount you want to pay.